Good morning. I am presenting the case of one 75-year male patient. He presented to hospital with complaining of altered mental status and some delirium-like features. He was talking abnormally since yesterday night. So his history goes like he is an 75-year-old male patient. He is having chronic alcoholic patient, and his BP in the admission time was 210 by 120 something. So what with this gross idea, what you have to suspect is we have to suspect high BP with altered mental status without a neurological conditions with the neurological condition. You have to differentiate like this. So first one condition is I am discussing this condition because this is one unique condition presenting like there is something called as Wernicke encephalopathy. So this is a Wernicke encephalopathy. There is something disorder related to neurological disorder, which is related to only like he was having criteria some like he was having ataxia and altered mental status, confusion and nystagmus, and these are the only thiamine deficiency. So Wernicke encephalopathy, there is something called thiamine deficiency disorder that affect the neurological system with presenting with the classic clinical triad of ataxia and nystagmus and sometimes vertigo, sometimes posterior like cerebral stroke signs. So what you have to do is with this complaint he is presenting, we have to differentiate like some differential diagnosis goes towards first either it may be a stroke or it may be a Wernicke encephalopathy or it may be any other hepatic encephalopathy or it may be any posterior cerebral stroke and everything. So you have to do all these things. So because of these things, what you have to do is first you have to clinically you have to examine. If it is a stroke, what are the symptoms present to stroke? If the patient, however, he is a known case of hypertension and he is presented with high BP. So what you have to high BP with altered mental status, if he presented, if the same patient presented with complaining of high BP, altered mental status, or any of the side is limb weakness, and if it is there means with other causes of the stroke, if it is there means we have to suspect that there is something related to stroke. As there is a high BP, it is maybe hemorrhagic stroke. Either it may be hemorrhagic stroke or it may be ischemic stroke. What you have to do is you have to take CT brain, have to rule out whether it is any bleed or not. If any bleed is not there, we have to go normally. So there is no stroke in this patient. I am suspecting there is no any stroke because there is no power is normal, and the patient is having only, and depending on he says he is having only ophthalmoplegia, like his eyes were he is having nystagmus and ataxia, confusion is there. Due to this condition, I am not suspecting any other stroke pathology because his power is totally normal, his limb power is normal, and there is no any other causes of the stroke. So what you have to do is, this is not a stroke. I am not telling completely not a stroke. We just go towards the differential diagnosis. So one other condition, as his typical history shows up, either it may be a posterior cerebral stroke. So what I have to do is I have examined all the posterior cerebral signs examination, like finger nose test and the dysdiadokinesia, and other one is like I have examined for the pendular knee jerk and all these things like vertigo, ataxia, everything he is having. I am examining all these conditions. He shows up only 50% of all the clinic cerebral signs what he is having. So either it may be a cerebral stroke or it may be a Wernicke encephalopathy. Very interesting part, like Wernicke encephalopathy I am discussing because this is a only reversible condition if it is treated and if it is diagnosed in the early stage. What you have to do is how you have to go for the Wernicke encephalopathy. If the patient is having presented with some ophthalmoplegia, confusion, ataxia with history of severe alcoholic patient. As this patient is having severe alcohol, he used to drink a lot. So because of this severe alcoholic condition, we presented this complaint, and there is no any present signs of stroke. What you have to do is either it may be a what you call as thiamine deficiency disorder, that is Wernicke encephalopathy. What you have to do is in specific to Wernicke encephalopathy, it shows that its treatment prognosis is very danger. Like if you treat early, it will reoccur very normally. It will become a normal. If we are delayed in giving thiamine injections, everything, there will be a problem with some other causes. Like they will go into coma, they will go permanent death. Sometimes the patient will die because of the severe thiamine deficiency. What you have to do is you have to differentiate. This one I am differentiated with stroke. There is no stroke because of there is no any power loss and there is no any anything stroke signs is not there. And I am suspecting there is no any hepatic encephalopathy, because if it is a hepatic encephalopathy, patient will present with mild coma or with a history of some other causes of the hepatic encephalopathy like flapping tremors. And sometimes first flapping tremor is usually in hepatic encephalopathy. Flapping tremor will see in the fourth stage, like in the 3 to 4 stage. Early stage of hepatic encephalopathy, they will present with complaining of night they will not sleep and daytime they will sleep. This is a mild hepatic first stage of hepatic encephalopathy. There is no any criteria, and he is developed since yesterday only, sudden onset of these conditions. And if it is this, so that there is no any hepatic encephalopathy, and he is passing the stools also. And there is one I am interested in posterior cerebellar stroke, and either it may be posterior cerebellar stroke or either it may be Wernicke encephalopathy. I am suspecting posterior cerebellar stroke because of the patient is having severe giddiness. He is unable to stand. He is having ataxia. He is having dyskinesia, and he is having pendular jerk. And other also he is having all the signs of posterior cerebrals, like cerebral examination I have to do. So because of this condition, I am suspecting posterior cerebral stroke. One more is patient is having nystagmus. You can see patient is once if you turn the patient like this, patient will have unilateral nystagmus. The patient is having unilateral nystagmus and all the vertigo with the cerebral strains. So maybe this is because of the posterior cerebral stroke. One more thing is I am suspecting encephalopathy, like Wernicke encephalopathy, because of the patient is having severe alcoholic history, with presented since yesterday only he is presented the same complaint. So what we have to do is we have to give the Thaimin injection now. Yes, we have to take. There is no any specific test to diagnose the Wernicke encephalopathy. MRI we have to see, because there in MRI finding they will not give this is a case of Wernicke syndrome. They will not give. How we will diagnose is because in MRI they will show some dilated ventricles with thalamus hyperintensity in the thalamus with dilated ventricles. If it is there, means we have to suspect the case of Wernicke encephalopathy. We have to start giving the Thaimin injection. So one more thing is in this differential diagnosis. One more differential diagnosis: normo pressure hydrocephalus. There will be a hydrocephalus which is related to either high pressure, like high BP. If the patient is having normo pressure, like his BP is normal, and if the ventricles were like hydrocephalus, he is having dilated ventricles in the brain. So this is also one of the differential diagnoses. So what you have to do in patient of Wernicke encephalopathy, treatment is only Thaimin replacement. One thing important thing is yes, we have to go for MRI. After MRI report, we have to give Thaimin. No, if you are going with delay, the patient condition will be worsened, because Thaimin permanent damage to the brain may be occur, and some complications of permanent neurological deficiency, permanent coma, permanent death may be occur. So what you have to do is we are suspecting some Thaimin injection. You have to give supplemental Thaimin. After giving Thaimin only, you have to send for the MRI. So what are the doses of Thaimin injection in the patient of Wernicke encephalopathy? Is like 500 mg of the 500 mg Thaimin injection 3 times a day, like 500 mg TID into 3 days. After that 500 mg BD into 3 days. After that 1 OD into 3 days. After that Thaimin tablet 200 mg tablet can be given to be continued. So this is very important. Now we are suspecting this condition. I am not showing the clinical examination because patient is so he was unable to stand, unable to he was having severe giddiness. So only dose, just you have to remember, Thaimin Wernicke encephalopathy is a Thaimin deficiency disorder, which is a neurological disorder characterized ophthalmoplegia and coma, and not a coma, ophthalmoplegia, confusion, and some nystagmus conditions. So this, if it is there, means we have to suspect with alcoholic history. We have to suspect some Thaimin deficiency. Usually there in this era there is no any Thaimin deficiency, because every diet we are having Thaimin deficiency. Thaimin means nothing but a vitamin B1. So what you have to do is we have to suspect Thaimin deficiency only if the patient is having severe alcoholic and other signs, like if the pregnancy patient, they will have a hyperemesis gravidum. Like patient pregnancy, they will continuously vomiting after vomiting. They may have some Thaimin deficiency. In these conditions, we have to suspect the same patient, or the patient is having old age patient, he was having continuously vomiting, which is followed by the unconsciousness. What you have to do is continuously vomiting followed by the unconsciousness. We have to suspect the Thaimin deficiency. So these have to be ruled out, and I am sending this patient for MRI to rule out these two conditions. So before sending, I am giving the Thaimin supplement. So thiamine supplement, there will be thiamine injection. Directly we can give 1 ampoule contains 100 mg. So it will be 1 cc injection. It is contains 100 mg. There will be 2 cc thiamine injection is there. It contain 1 cc contains 100 mg. So we have to give 500 mg stat. 500 mg means 2.5 ampoules, like total 500 mg injection in the thiamine. So one more thing, how to give the thiamine injection? We have to give with the glucose or anything else. So only one important thing is we should not give glucose in the patient of Wernicke encephalopathy without a thiamine injection. So because glucose will decrease the same like its pathology will be the decrease in the brain. So what you have to, either it should be given with the glucose. After the thiamine injection, glucose can be given. Before the thiamine injection, glucose should not be given. Either it may be given with the thiamine injection. After the thiamine injection, glucose can be given. So what you have, with the DNS we can give this. And there is an optineuron injection. It is contains is 3 ml injection. 3 ml injection contains, there are other vitamins also there, but thiamine 100 mg is there. So this 100 mg thiamine injection is there in the optineuron. We can, for this patient we can give some stat dose like 500 mg you can give, or either if 200 mg at least 2 ampoule have to give, and after that you have to send for the MRI. We have to see for this MRI report. If it is not a posterior cerebral stroke, we have to treat with the thiamine injection. That is 500 mg TID 500 for 3 days, 500 mg BD for 3 days, 500 mg OD for 3 days. After that thiamine tablet to be continued. And this is the treatment. If it is a cerebral stroke with the thiamine supplement, we have to give the if it is a hemorrhagic stroke or ischemic stroke. If it is a ischemic stroke in the posterior cerebral, we have to give some heparin injections and ecosprin tablet, everything to be given according to the treatment. If it is hemorrhage, we have to give the mental everything, or 3% limits have to be given, and we have to treat the respectively.